Welcome to Chapter 9, where we talk about cannabis. Cannabis is an area of study now that has really taken off in the last 25 years. We now see medical marijuana everywhere. If you were anything like me, I did not know a lot of the difference in the different terminologies or understanding how you would ever medically dose marijuana or cannabis. Like, I didn't understand the THC and the different properties and all the different forms of cannabis and how they're broken down. There is actually a lot of detail in prescribing cannabis and marijuana use for medicine. And so I'm going to kind of go off a little bit, and I want us together to watch this video from the Osmosis to talk about the cannabis and really help them describe it to us so we have a better understanding out of the gate to talk about this chapter.
Cannabis, or marijuana, is one of the most popular psychoactive substances worldwide, especially among teenagers. Although the specifics of cannabis's addictive qualities are still very much under debate, cannabis dependence disorder is officially classified in the DSM-5, and prolonged heavy use has been shown to cause some level of dependency. Cannabis comes from the flowers of cannabis sativa plants, which has oils with concentrations of tiny, fat-soluble psychoactive molecules called cannabinoids. The three main cannabinoids, tetrahydrocannabinol, also called THC, cannabidiol, also called CBD, and cannabinol, also called CBN, are each associated with unique psychoactive effects. For example, THC is associated with high-grade recreational marijuana, and produces effects like euphoria, analgesia, mild hallucinations, and an increased appetite. Cannabidiol, on the other hand, does not have psychoactive effects, and is commonly included in medical marijuana because it has a variety of effects including being analgesic, anti-inflammatory, anti-seizure, appetite stimulating, and anxiety reducing. To understand how cannabis works, let's zoom into a synapse of the brain to see how a stimulus response is induced generally, without drugs. Normally, electrical signals or action potentials travel down the axon to the axon terminal, triggering the release of chemical messengers called neurotransmitters from synaptic vesicles into the synapse. The neurotransmitters travel across the synapse and bind to receptors on the postsynaptic neuron, where they give the cell a message. After those neurotransmitters have done their job, they unbind from the receptors and can simply diffuse away, get degraded by enzymes, or get picked up by proteins and return to their release site in a process called reuptake. When cannabis is consumed, the cannabinoid compounds it contains bind to cannabinoid receptors, which are found in the central and peripheral nervous systems, as well as certain types of cells, like immune cells. These receptors are normally stimulated by endogenous cannabinoids, also called endocannabinoids. A real-world example is the runner's high phenomenon, in which a naturally occurring endocannabinoid called anandamide gets released during strenuous exercise, making the runner feel less anxious. The way it works is that anandamide is released from postsynaptic dendrites, and it diffuses retrograde, meaning backwards, to the presynaptic terminal where it binds to the cannabinoid receptor. At that point, there are intracellular changes that ultimately lead to a change in the flow of calcium and potassium across the presynaptic cell membrane, which inhibits depolarization. So the presynaptic nerve terminals stop releasing neurotransmitters like GABA and glutamate, which reduces neuronal excitability, a process called presynaptic inhibition. In summary, anandamide from the postsynaptic neuron basically pumps the brakes on neurotransmitter release from the presynaptic neuron, and the result is a feeling of calm. Because THC has a similar chemical structure to anandamide, it can bind to cannabinoid receptors and trick the body into producing a similar feeling, minus the hard work of a strenuous run. In fact, cannabinoids are extremely lipophilic, meaning that they can easily get into the central and peripheral nervous system and can stimulate receptors for much longer than endocannabinoids, creating a prolonged effect. Now, there are two types of cannabinoid receptors, cannabinoid receptor type 1 and 2. Cannabinoid receptor type 1 is mostly found in the central nervous system, and is highly concentrated in areas like the cerebral cortex, cerebellum, hippocampus, basal ganglia, hypothalamus, and spinal cord. Cannabinol binds to cannabinoid receptor type 1, slowing down activity in those parts of the brain, which results in mild hallucinations, decreased stress, impaired learning and memory, altered movement and coordination, increased appetite, and analgesia. Activation of the cannabinoid receptor type 1 also activates the body's endogenous opioid system, releasing dopamine into the nucleus accumbens to produce feelings of pleasure and reward, which explains why the pathway can be addictive. In contrast, cannabinoid receptor type 2 is found on immune system cells and peripheral nerve terminals. Cannabidiol binds to cannabinoid receptor type 2, inhibiting their activity and producing anti-inflammatory and analgesic effects. THC, on the other hand, can bind to both cannabinoid receptor type 1 and cannabinoid receptor type 2, and therefore has a wide variety of effects. Now, the pharmacokinetics of cannabis differ depending on whether the cannabis is smoked or consumed orally. The majority of recreational users smoke cannabis via rolled cigarettes called joints, as well as in pipes or with vaporizers. The cannabis in a joint contains a compound called tetrahydrocannabinolic acid, which has to be heated to become psychoactive THC. The process of heating actually destroys about a third of the THC, and more is lost with exhalation and side stream smoke, which is the smoke that leaves from the end of the cigarette or pipe. So only a fraction is inhaled and absorbed into the lungs. Inhaled THC goes from the lungs to the bloodstream and gets into the fatty tissues of the brain and body where it can accumulate. That's why the effects of smoking cannabis can be felt within minutes and can last several hours. Edibles, on the other hand, are consumable products that contain cannabis, and they also have to be heated to transform tetrahydrocannabinolic acid into psychoactive THC. When a person consumes an edible, digestive enzymes break down the majority of the THC, leaving behind only a portion of the THC to get absorbed into the bloodstream. Blood from the gastrointestinal tract gets delivered to the liver, where THC gets metabolized, and it leads to the formation of 11-hydroxy-delta-9 THC. This is a psychoactive metabolite even more potent than THC because it can more easily penetrate the blood-brain barrier. This largely explains why individuals who consume cannabis rather than smoke it experience more intense psychedelic symptoms. Alright, let's step back for a second and say that you're at rest, without anything stimulating your reward pathway. In this situation, your brain keeps your heart rate, blood pressure, and wakefulness in a normal state, called homeostasis. Now let's say that your boss sends you a text. All of a sudden you might feel sweaty and flushed, and your heart rate might jump a bit. You're now above your normal level of homeostasis, because something's changed, right? But it doesn't stay that way for long, and after the text, your brain brings things back down to baseline. With repeated cannabis use, a few things start to happen. Let's say you smoke or ingest it at a specific time and setting, like on the porch at 6 p.m. after dinner. You then start to feel a little sleepy, but you're also still hungry, and maybe a little anxious about work or school tomorrow. So you grab an after-dinner snack, tune into a TV show, and zone out until you fall asleep. Now, your brain picks up on that pattern. Next time at 6 p.m. on the porch, your brain reminds you of the great time you had last night eating chips and watching Netflix in bed while you were high, making you want to do it all over again. Now let's say that your 6 p.m. after dinner porch time rolls around, but you don't have any cannabis. In that situation, you're still anxious about work tomorrow, but you have no cannabis to distract you and make you feel tired, so you can't sleep. You feel irritated, and end up feeling even more anxious than you did the past couple nights when you were able to smoke. When you stop using cannabis, you might experience mild withdrawal symptoms like cravings, irritability, anxiety, and difficulty sleeping. These symptoms, though, aren't lethal because there are very few cannabinoid receptors in the brainstem, so respiration and vital signs are unaffected by cannabis use, but they can be pretty uncomfortable. Discomfort and craving could make you want to smoke again, and lead you to develop that pattern of problematic use and dependence. Teenagers have a particularly high risk of developing cannabis dependence because the developing brain's reward centers are more sensitive to the rewarding effects of cannabis. Remember, neurons that fire together wire together. People who use cannabis heavily from a young age will end up with different reward pathways than those who don't. Problematic cannabis use and dependence are characterized by behaviors like smoking more often or for longer than you intended, being unable to cut down, spending excessive time finding or using the drug, and craving cannabis. You might also have a problem if your use negatively affects your ability to work, go to school, stay physically safe, or have a positive home life and healthy relationships, especially if you continue to use despite having those problems. Finally, you might be dependent on cannabis if you develop tolerance to its effects and need more to feel high, or if you experience withdrawal symptoms. Severe cannabis dependence has been associated with the development of anxiety and depression, as well as psychotic disorders like schizophrenia. It is difficult, though, to establish causality, and it's also possible that individuals already predisposed to mental health problems may be using cannabis to self-medicate. Research into the long-term physical effects of cannabis is also ongoing, and there seems to be an association between smoking cannabis and hyperinflated lungs, chronic bronchitis, and an increased risk of respiratory infections like pneumonia, as well as a tentative association with heart attacks and strokes. Cannabis dependence is largely focused on reducing usage, often through a combination of medication and treatment. One medication that helps with symptoms of cannabis withdrawal is an anti-anxiety medication called buspirone. Most behavioral treatment involves individualized psychotherapy or group programs. One specific technique is called motivational counseling, which is a goal-oriented counseling style that helps individuals explore and resolve their ambivalence about a behavior. Alright, as a quick recap. The THC in cannabis mimics naturally occurring endocannabinoid neurotransmitters and creates positive reinforcement of usage through feelings of euphoria and negative reinforcement of use through withdrawal symptoms when usage is stopped. Long-term use can in rare cases lead to dependence, which is the reliance on the cannabis or THC to function normally. The most effective treatments involve behavioral therapy, with a lot of love and support from family and friends. Thanks for watching. If you're interested in a deeper dive on
You guys find that helpful to kind of talk about the receptors and all of these things before we jump into this lecture. Now, obviously, that was meant to talk a little bit more about cannabis in terms of if you get addicted to it or, using it as a quote unquote recreational drug instead of medicine. But I think it's helpful to give us that perspective. So today we're going to discuss the pharmacokinetics, pharmacodynamics, and the potential adverse effects of cannabis, which we learned about in the video. It has been listed as in being used for medicine since 2000 BC. It has literally been around forever. It was first noted in the U.S. Pharmacopoeia in 1851. Currently, it is a Schedule I drug, and it is used as a medical use for cannabis in 37 states, 4 territories, and Washington, D.C. These are the different components we need to review, so let's get into it. The endocannabinoid system. Talks about the endocannabinoids, the 2-AG, etc., and then the cannabinoid receptors. So this is what the video kind of helped us get into, was that the endocannabinoid system contains endocannabinoids, their receptors, and the enzymes that are associated with their synthesis and degradation. Cannabinoid receptors are G protein receptors activated by endogenous endocannabinoids, cannabinoids from cannabis, and synthetic cannabinoids. Okay, so we have the cannabinoid receptors CB1, CB2. The first endocannabinoid identified, anandamide, is a partial agonist for CB1 and CB2. Both anandamide and a second endocannabinoid, 2-AG, are synthesized on demand by the body and have autoprotective effects. Okay, don't get too caught up in memorizing all this. We just need to understand this idea that CB1 is in the CNS, and CB2 is in our immune cells, our bone marrow, and our brain. Okay. When we say central nervous system, we are including basal ganglia to affect our motor activity. We're talking about cerebellum for motor coordination. We're talking about hippocampus for short-term memory, neocortex for thinking, and the hypothalamus and limbic cortex for appetite, gastric motility, and sedation. CB1, CB2 receptors are expressed during inflammatory and neurogenic conditions. So that's why we think that we can use them in medicine. Okay. When stimulated, the CB2 reactors are not psychoactive, which helps us understand how we get into now the cannabinoids as a... So the plant has 400 phytochemicals, 104 cannabinoids, and can be broken down into THC or CBD and other molecules, right? So we know that when we're talking about using marijuana for medicine use, it is important. Are we talking about the THC? Are we talking about the CBD? And that does matter because the THC is the part that has the psychoactive properties and the CBD has no psychotropic properties. So that's why we can argue, or people argue, that when you just use the CBD, you're not using it to get a high, you're not using it as a recreational drug, you're literally using it for its other properties that can be considered medicinal. All states with medical programs require delta-9 tetrahydrocannabinol content to be listed on their product label. So in other words, everybody has to put if they add THC properties into their product. Interestingly, the merging of the recreational and then the medical programs in many states has led to evidence that the potency of the THC content is much higher for medically advertised products than is clinically warranted, which has led to untoward effects. In other words, it's become problematic. So the Food and Drug Administration approved products on the market are listed in Table 9.1. Epidiolex is a CBD-only product that the FDA has approved for the treatment of 3 types of seizures. Dronabinol is Marinol, is a synthetic cannabinoid that's a Schedule III controlled drug that we've used for a long time for nausea and vomiting with cancer therapy or anorexia with AIDS. Nabilone, which is Cisamet, is a Schedule II synthetic cannabinoid approved for nausea and vomiting in patients receiving chemotherapy. Sativex, which is nabiximols, is a product approved in the United States and 30 countries used to treat spasticity as an oral mucosa spray associated with multiple sclerosis. We can get cannabis in a multitude of different ways, right? Oral, inhaled, intranasal, mucosal, transcutaneous, topical, and parenteral even. And each of those are going to have their own kind of issues or things to go along with it. Important things to know: when cannabis is smoked, it's going to be absorbed through the lungs, and the onset is within minutes and can last 1 to 3.5 hours. You can have vaporized cannabis products that can produce pharmacodynamic effects that are even greater and higher to give you higher concentrations of THC. So vaping cannabis is going to get you very high. When we take it orally, it's absorbed in the intestine and it can last 5 to 8 hours. Orally ingested THC is converted in the liver for the first pass effect, and it can have the long-active metabolites. So those are important things to kind of remember there. The pharmacodynamics of cannabis is really tough because there's multiple active ingredients. So when we're talking about how do we really understand the pharmacodynamics, we have to really look at what are all the different active ingredients, which receptors are we working with, XYZ. And so it can actually be quite intense or labor details intensive, so to speak, on how to understand the pharmacodynamics of cannabis, because we need to understand, are we working with THC or CBD, and what formulation or preparation it's in as well. Both THC and CBD are highly lipophilic. They want to stick to the fat in our bodies. They are both metabolized by the liver. So if you have liver disease, that can affect the pharmacodynamics of the product, no matter how you're taking it. National surveys have shown that 7% of adults using cannabis medically is existing out there. Those using cannabis medically most commonly report they use it for anxiety, insomnia, pain, and depression. It can be used for epilepsy, spasticity, sleep disorders, PTSD, Tourette's, depression, cancer-induced nausea and vomiting. There's a lot of indications out there now of how we could use cannabis. Your table 9.1 in your book is nice because I think it does a great job of breaking down the active ingredient, so the THC versus the CBD, and talking about approved for proposed uses. The THC is what we think can be helpful for pain, whereas the CBD is more helpful for like anxiety. And then it breaks down the different drugs as well. A couple other things to talk about is that they have studied cannabis extensively for appetite in patients with AIDS, and it did not stand up to the muster. There was no evidence to say it was super effective. However, the dronabinol for the specific population of HIV did show some promise, so that's why it has that indication. As far as anxiety goes, it's been pretty inconclusive, actually. Chronic pain is the most common reason that people will use medicinal cannabis. When they look to the literature and the studies, there was 28 randomized controlled trials of patients with chronic pain. In 8 of those trials, 30% of patients reported improvement of pain over the controls. And so based on the current evidence, the powers that be concluded that there is substantial evidence that cannabis is an effective treatment for chronic pain in adults. Another meta-analysis evaluated the efficacy of cannabis for both cancer and non-cancer pain, and they found that there was a moderate to high certainty of evidence that non-inhaled medical cannabis results in a small to very small improvement in pain and improvement in physical functioning and sleep among patients with chronic pain. But they also had several transient adverse effects. And then important to understand that although cannabis has been shown to be effective for chronic neuropathic pain, relief requires the use of the THC component, which then will give you the psychoactive effects and possible for dependence. There's been a lot of discussion about the use of cannabis in epilepsy, and there's some very specific types of diseases that have been shown to be effective for the use of cannabis, often in pediatric epilepsy. As far as post-traumatic stress disorder goes, there has been one fair quality double-blind randomized controlled trial of nabilone in veterans with PTSD associated nightmares. Their nightmares, their global clinical state, and their well-being were improved more with the nabilone than with placebo. Another double-blind randomized placebo-controlled trial used smoking cannabis compared high THC, balanced THC or CBD, or high CBD for PTSD symptoms in military veterans, and none of the active treatment arms were superior to placebo. So there's mixed results on that as well. There can be, for certain, adverse drug reactions and adverse effects of cannabis. And this is where it gets really tough to argue that these are going to be like the miracle treatments, right? Because they do have these adverse effects and they're not nothing. So one of the first ones is its reproductive effects. So the trouble is that people using cannabis recreationally, for sure as well, frequently use it during childbearing age in women, right? So there is evidence and substantial evidence that there is a statistical association between mothers who smoke marijuana and low birth weight infants. It's very similar to cigarette smoking. We also know that similar to cigarette smoking, the maternal carbon monoxide and carboxyhemoglobin levels are elevated when they're smoking cannabis, which directly impacts poorly the fetal growth. So, although cannabis can be present in breast milk, there is not conclusive evidence at this time whether or not the infants would be exposed to it or not. So, I cannot imagine that we would err on the side of advising someone who's actively smoking marijuana and using cannabis regularly to breastfeed. When we talk about cancers, there is no evidence for increased lung, head, or neck cancers in those who smoke. However, in a systematic review of 3 case-controlled studies that had over 2,000 participants, they looked at the association between cannabis and testicular germ cell tumors. The participants who reported ever smoking cannabis had a statistically significant increase of risk of developing testicular germ cell tumors. Now, I feel like if you put that on the packaging of cannabis to use recreational for young men, that might be a really great deterrent, potentially. But this is not nothing. This has been well documented and shown to be very true. Then we can have the cognitive and psychosocial effects. So there is very clear evidence that if you have used cannabis within the last 24 hours, it does impair your cognitive performance, including your learning, your memory, and your attention. So evidence for ongoing impairment of cognitive function after stopping the cannabis has been seen in a few studies. Of more concern is the effect of cannabis on the developing adolescent brain, you guys. So when we know that when you use cannabis during adolescence, it is related to impairments in subsequent academic achievement and education. It is impairing employment and income, and it has negative social relationships and social rules. So they have studied this extensively. People using cannabis in adolescence, they don't have good outcomes. This is not good for them in the long term. The other thing is the difficult side effects for mental health, right? So it's difficult to determine because there's a lot of things to look at when you're talking about that. The studies looked at multiple systematic reviews before concluding that cannabis use does not appear to increase the likelihood of developing depression, anxiety, or PTSD. But, with a big but, cannabis use is likely to increase the risk of developing schizophrenia or other psychosis. The higher the use, the higher the risk. Okay, again, it's like, can we put that on the label packaging, please, to kids buying marijuana? Likewise, patients with bipolar disorder who use cannabis daily have more bipolar symptoms, and heavy cannabis users report more suicidal thoughts than non-users. This is very well studied, you guys, across the literature. This is not just one random study of 20 people. In fact, the label for Marinol includes a warning that it can exacerbate mania, depression, and schizophrenia, and that you shouldn't even give it to people until they're screened for their psychiatric history. So, in summary, cannabis use for recreational and medicinal purposes has increased significantly over time. There's numerous studies that have documented some of the benefits, specifically, like we talked about, pediatric epilepsy, some cases of insomnia. In the cancer world, it can be helpful for chemotherapy-induced, let's fix that because that's annoying, nausea, and that we as prescribers were going to come across it. This is what I can also tell you on the use of medicinal marijuana. When people are being prescribed medical cannabis, what they're talking about is that you are going to be telling them to take a dose based on their parts of THC and CBD. So, for example, if a patient is naive to cannabis, the typical advice is that you start with equal parts THC and cannabinoid, so that you would take like a 2.5 milligram THC and mixed with a 2.5 milligram CBD as a tablet, and then they would adjust their dose on that. They do acknowledge that patients who are experienced with cannabis often need cannabinoid formulations that are THC predominant, meaning you get twice as much THC as you do to like cannabinoid. So that to me means that people that are getting used to being on the cannabis start to need heavier THC sites in order to get the effect that they're looking for. And so that has to take into account a couple of things, right? Is that obviously people are getting some of the THC side effects, and that is what they need to feel the benefit for their condition, is what I'm trying to say. Most people that are on medical marijuana have some kind of treatment agreement that they have to be honest about everything that they're taking. Oftentimes people with chronic pain or cancers are also on opioids, so there's that risk of commingling the two together. There is definitely the purpose of talking about management of it and then withdrawal. People that are on it for a long time will have withdrawal issues. And so cannabis withdrawal is a real thing. So you could see somebody coming into an emergency room, for example, and really be in the pickle because they're in a withdrawal state that they couldn't get their medical prescribed cannabis, and they have been using it long enough that to go without it, they're up a creek, so to speak. Some of the knowledge check here. There is clear evidence for which of the following adverse effects of cannabis: headache, lung, head, neck cancers, impaired cognitive performance, or anxiety. And the answer is impaired cognitive performance. We do know that people that use cannabis have a decreased learning, memory, and attention span for up to 24 hours. This is really worrisome for the adolescent. Which of the following cannabinoid products has been approved as an adjunctive treatment for reducing seizures? Okay, and it is the Epidiolex, which is epilepsy, right? So Epidiolex, the epi is how I remember that as well. Specifically, it's with Dravet or Lennox-Gastaut pediatric seizures. And this is actually has been life-threatening. The children that have this, that get on Epidiolex, which is a significant cannabinoid dosing, they will have a dramatic improvement of their life. The kids with these kind of seizure disorders are the ones that don't live a very long time. They seize over and over and over and over all the time during the day, like they can hardly live because of their seizures. So for them to be able to have access to this drug has literally been life-changing. Okay, that's a short and quick and dirty review of Chapter 8, Cannabis. See you in Chapter 9.